Welcome to the Functional Code, your go-to source for decoding optimal health. Join Dr. Addy and Dr. Jace as they break down the science behind pain, performance, longevity, and more, making complex concepts easy for you to understand and apply in your life. Your journey to a healthier you begins with understanding the Functional Code.
Disclaimer: the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Welcome back to the Functional Code. Today we're going to be working on and focusing on the hip complex, the pelvis. We have a lot of information. I'm Dr. Jace.
I'm Dr. Addy, and we're excited to bring this to you guys today. Like always, we're going to talk evolution and understanding of the pelvis, how it changed over time. We're going to get into common conditions such as hip labrum tears, hip osteoarthritis. We're going to talk bursitis. We're going to talk the understanding of the pain patterns around the hip and how it associates with the low back, with the SI joint. We're going to get to all that fun stuff. Lastly, we're going to give you guys tools to take home so that you guys can manage your own issues, especially when it involves with the hip. So, Doc, let's get into today's podcast. Number one, how did the pelvis change over time, and what are the main differences that we see, especially between genders, when it comes to the pelvis and hip?
When we look at humans, male to female, us humans, females naturally have wider hips, a little bit larger pelvis, more for childbirth. Now, that changes for men. Men have a little bit more taller pelvis, which also allows to hold up more pressure of our upper torso against gravity. And you're also going to see that change a little bit from the ancestors a couple million years ago, from a species known as Australopithecus. So there's a fossil they found in Ethiopia in the early 2000s. They named that fossil of the specimen Lucy. You can type in Lucy ancestor million years ago, and there's a bunch of information that can come across there. But we're going to bring up a couple different things from that. So what we know, and I touched on this last podcast, the height of that species was anywhere from 4 foot 2 inches to 4 foot 8 inches.
Tiny.
A little bit.
That's tiny.
And almost a little bit more wider stature.
Okay.
There was a few differences. The one of which, when we look at the pelvis relating to the hip, the pelvis was much thinner back then, but it also was wider. Now, with that, I think that was definitely, we're theorizing again for the evolution from apes, chimpanzees, and that type of species to where we're at right now. And we can see some common tendencies, especially between chimpanzees, Australopithecus, if we will, and then humans. So there's a few challenges that came up with that. One of which is that this circle, or this pelvic canal, if we will, that's got more narrower. And that's also, as females give birth, the baby has to come from the womb out through this area, and you have to have the tailbone open up. So for them having a narrower pelvis, almost like an oval instead of a circle, that I think created a lot more problems. I also think that's where, and again theorizing, where childbirth was way more traumatic for them, also for the mothers as well. So the survival rate and how important females are, not only now, like we all respect and need females, but back then and how we've evolved, thank God we are where we're at right now, just based on that aspect. But with the wider pelvis, naturally, it forces a little less muscle or gluteal structures, and it forces more muscles on their legs of the thighs, whether it's quads, hamstrings, thus where some of the power came from. With also a wider pelvis, increase what's known as the Q angle, and we brought this up in a few other podcasts as well. The Q angle is the side of the pelvis hip and the angle to the inside of the knee. Now, with females often having wider pelvises for childbirth, and their knees coming inward naturally, that angle is larger, thus a larger Q angle, versus males, not as wide of a pelvis and less of a Q angle. So when we also look back on some of the adaptations, they appear to have a thicker knee joint just to stabilize the hip, and I also think that's also due to a lot of the muscles of the thighs being able to house those structures. Now, it was weird, Doc, I didn't bring this up with you, but I had like a dream last night to where I was sleeping seated, and I felt like I was in like a tree or like a forest area, and I was like leaning off to the side. So I'm thinking, okay, is that how they slept? And I don't know, it's just weird.
Really?
I mean, from some of the stuff last night, I think, yeah, I
That's
don't know.
interesting.
So
You know,
maybe.
What's interesting is when you had talked about the pelvic bowl, I would guess that the reason why Homo sapiens are where we are and evolved to us is we probably evolved to have that pelvic structure so that we could reproduce more. And so eventually we had less traumatic birth. We could actually reproduce more with less outcomes, or excuse me, less traumatic outcomes. And to why maybe that type of species didn't thrive as well. Not to say that they weren't combative or athletic or what have you, but just because they couldn't reproduce as well.
Exactly.
You know,
we have to
pelvic
survive.
structure-wise. You're right.
Absolutely.
Makes a lot of sense. To your tree statement, I have no idea how they slept. What I do know is I wonder when like the first hammock was made, because I bet you that's how they first. Because my guess is they had to get away from predators somewhat, unless they started figuring out shelter-wise. But if they did live in the trees mostly and didn't understand shelter, or at least to that standpoint, because again, that's back to the talks of us climbing and hanging from trees and how we evolved with our forms, like the last episode. How did that change? If we were tree dwelling, then somehow to hang into the tree, because sleeping off a branch, unless the trees back then were ginormous, I have no idea. That makes a difference, though. It's kind of funny.
It's really weird, man. Yeah, and then the one other part that I found kind of fascinating, which it makes more sense with kind of how the structure was put together, the acetabulum, or where this ball hip joint attaches kind of in that like canal, or the acetabulum. For the Australopithecus species, that, and much the same with chimpanzees and monkeys, that was more just on the direct side instead of down and pointed more like inferior laterally. So instead of the hip joint being facing out and down, it was straight out to the side.
And that's chimpanzees, you said?
Chimpanzees have the same thing, and it was the same structure as the Australopithecus species as well. So there's different studies that I think they're more theorizing based on bone structures and how different stress is on different parts of the bones. As the structure became more out and down, it forced our bodies to go into bipedalism, or stand up against gravity. That also forced the labral tissues and the ligaments and tendons around the hip capsule to stabilize, thus for locomotion, versus how they were back then, where it was just kind of off to the side. They're much easier to get into a squat because the rim, the back of the rim, allowed for more rotation and has, for us right now, more stability, which I think is also why it's hard for most human species to get into a full squat with less pain naturally. I mean, when we're babies, we can get to squats and we can play around, but as we grow and adapt against gravity, the capsule tightens up and there's limitations.
And as we became weight bearing on 2 feet, it makes sense that hip structure became so just stabilized and tight, because we're going to get into the structure of the joint, the hip joint, in a little bit. But when we say it is incredibly stable joint, it is when you dislocate your hip joint, it sounds like a gun going off. It is so incredibly stabilized and suction in to that structure. It makes a lot of sense that it had to grow and become that way because of how much weight bearing we needed to now do on 2 feet instead of 4. So with that, Doc, do you want to jump into the hip joint, all the structures that create such a stable and just incredibly strong joint, and also some of the things that the pelvis inlays to as far as the hip joint as well?
When you look at the hip or the ball and socket joint of your femur to the pelvis or the acetabulum, there's different structures involved. Now, let's start deeper and then work our way out from there and the connections around. Again, this is not going to be an anatomy lesson. I just want your awareness to see how many different connections this hip has to many other areas of the body. So when you look at the deep hip, there's the hip joint itself. It's a synovial joint where there's membranous, slightly gel-like structure of the hip, which helps us move in many different directions. Now, overlying that to stabilize the whole joint, there's ligaments around the area, and they often go in more of a rotational fashion. So with that, the first thing lost with any human movement is internal rotation, or where the foot goes outward, but the knee goes inwards. And that is first lost, much the same to the shoulder with internal rotation. So when we look at different conditions, when we get to that in a little bit, that's where we first look at the assessment portion, and we see are there guarding tensions overlying it. And also with the joints, that's the first signal that gets brought up to the brain. Because there's no delay at the spinal cord, at an interneuron, it gets kicked up to the brain. And if there's any problem or lack of space at that hip joint, it's going to cause overlying muscle guarding. Now that guarding can or cannot have pain. It depends on what's going on. But if it doesn't have pain, it just has guarding tightness, it forces the pelvis to work up, and it forces the hips and the lower back to bleed energy to compensate into your lower back, thus lower back pain. So the lower back pain, and we're going to dive into the referral patterns. Doc's going to do an awesome job with that. But just to have a good understanding of when we do rehab, when we are understanding how the body works, it starts from the signal of the nervous system to the deeper structures first, and then overlying tissues from there. The overlying tissues are more of a guarding tissue regulation from that signal, but that's where we need to start. Now, as we go into the muscles and tissues around the area, I think it's important to understand the pelvis works as more of a stabilization for the whole body as a whole. So when you go into core to extremity movements or walking or throwing, a lot of it will come through the core. When I say core, I'm talking abs, I'm talking lower back, I'm also talking glutes. Now the muscles of the glutes, a lot of them start at the hips and then work either to the pelvic floor. A lot of them work to a certain extent up to the bottom portion of the torso. Some of them go to the lower back. A lot of them go down to the legs. There's different tissues, muscles, tendons, ligaments that cross the plane of the hip joint, which allows us to move in multiple directions. But based on the structure of how the hip is laid more on the front side, but more at a downward angle, that allows us to move in many directions in front of us, especially running, walking. However, with the glutes structure and the tailbone structure, it limits our movement of that ball and socket joint going forward, but your leg going backwards. So when we say that the shoulder is the most movable joint in the body, it's often due to and compared with the hip joint. But if our hips can't move backwards freely, much like our arms can, we have to make sure that we spend time in the areas behind us. Thus, so when the ball and socket joint of our hip, when that head goes forward, that helps bleed more energy on the front of the capsule. And if we don't do that, there's other problems that can come about that, which we'll get to here in a second. Everything around the area, core to extremity movement, works to a certain extent in unison with one another. The leg is either going to be moving forward, and if so, the opposite leg is going to be stabilizing. So when you look at soccer players having a strong, like if you're right-footed, you're going to have a lot more stabilization on the left side of not only your feet, but also your hip pelvis, which can create rotation in the pelvis and your tailbone, either one for the swinging motion or even outside that sport to force different compensations. So ideally, when you go into movements, you want to equal on both sides or spend more time on the area that your non-dominant foot is probably a good way to go about it, but we'll get into other tools here in a second.
Nice,
but,
nice. And
yeah,
I think one of the big things that people don't realize is, again, just how strong of a connection that hip joint is into the acetabulum. And I touched on that before, but the labrum itself, and that's kind of what we're going to jump into, it creates such an encapsulation around the femoral head. And what will eventually happen is if that labrum becomes compromised in any such way, such as narrowing of the labrum, if there's a tear, you will then lose the ability to have a proper gliding motion. And you'll almost feel as though there is a clicking or maybe a breakdown, maybe even a locking mechanism with an acute labral tear. But in the dysfunction or even things around it that can cause pain or issues to the labrum, such as what's called FAI or a femoral acetabular impingement, what you'll notice is you lose the ability to move a certain way because of just the compromise of now that gliding structure. And so, Doc, do you want to talk a little bit about the presentation of when patients actually damage that labrum and how the congenital changes around the acetabulum can actually impact hip movement and structure change?
well stated. Like, this is such a complex structure, and there's so many different pieces in play that we're trying to explain this in the best layman's terms as we can.
Yeah.
So when we look at even just a baby growing up, there's other conditions that can occur, whether that's that ball and socket, that femur and that acetabulum. There could be a shallow acetabulum to where that ball doesn't sit properly and it can slide out. That's what's known as the slipped capital femoral epiphysis, or skiffy, if we will. And that's where that ball can't hold the femoral head, and that's where oftentimes is found with checkups when we're younger, usually between the ages of childbirth or a couple months to a year or 2 years. And there's different bracing that babies and infants can do to make sure that they stabilize and house that ball back in the whole acetabulum. And then as the body structure goes against gravity over time, the labral tissues, the ligaments that hold that there, can have more pressure on them instead of the bone structure, which can lead to other problems down the road. So that's going to be one. There's also other conditions to where if you do have any problems with the labral tissue, whether it's a blow to, like an acute blow to the leg going backwards off to the side, are more common than if the leg would go forward from underneath you. The pressure and the recoil and the lack of give to that labral tissue can create more of an instability, and that's where certain people can notice popping, clicking. The joints could also have pain in the front of the hip. Like, there's a bunch of different problems that can come up from just the labral tissue, and there's different ways that you have to train that specific tissue over time. But yeah, Doc, that's, I think, a couple small things.
Yeah, and the reason why the acetabulum is so important when it comes to the labrum, this is common in hockey players. So the way that the shearing force and gliding force on the outside of that acetabulum can be a problem is if you already have either an outgrowth of the acetabulum. So Doc talked on a little bit of the shallow growth, but if there's an overgrowth, or even especially at the lateral portion of the acetabular rim, it can almost create like a little bit of a spur, a cup. And when you have that outer glide on the femur, it can have a pinching effect, and it can be very painful, and it can even limit performance. And so there are times where that pinching can also impact the labrum as well. So going into just the labrum of as far as managing that over time. Already the labrum, why it's important is not only does it help house an incredibly strong suction around the femoral head, but its main structure is to help and create a beautiful glide of an incredibly mobile joint. And when we lose the labrum, we now don't have that ability. So it's just like taking out any other piece of white tissue or cartilage, such as the meniscus, like we've talked about in the past. Now we already are predisposed to other things because we don't have that incredibly important structure, which the labrum can absolutely be for the hip. So in treating labral tears, Doc, what have you found as far as improving without surgery?
So yeah, there's a few different studies with this one. There's one back in 2018 by Kernigard et al., and they looked at arthroscopic surgery versus just physiotherapy for femoral acetabular impingement. And it was more of a prospective study. It was also randomized control trial, which is our top tier. They noticed pretty much patients that were going through physiotherapy treatments led to improvements in pain and function. However, the surgery had faster, shorter term, but I would definitely look to long-term perspective. Like, yes, if the surgery can get the pain improvements under control just as well as physiotherapy can, awesome. But when you look at these two together, you want to look at the long-term approach. Yep. So that's where when we look at rehabbing the hip, especially when it's impinging, you have to know where is it impinging and what direction or angle when you move the hip causes pain. You want to go not into that pain, but diminish the angle and apply muscle contractions to and from and in multiple different angles, thus so we can help rebuild the stabilization of the capsule. And that takes months to build up. Then you want to work into rotational movement, usually the 90-90 position, to where your front leg is 90 degrees in front of you, your back leg is 90 degrees, or just even sitting to where your legs are coming off to the side or something kind of like that position. And you want to force pressure into the area with bringing pressure of your foot down into the ground or lifting your leg up off the ground over time, just to build up that capsule. And then you can have bands for the recoil tension as well. But
the body is a beautiful
ways.
thing, and I know that training and PT is something that over time is, my opinion, the more appropriate approach to managing a labral or cartilage issue. And it's for the exact same reason that I just mentioned, where second you lose that tissue, you'll never get it again. It's not going to regrow. So that's where you have to just be conscious of that. When you start to take out that incredibly important structure, which you'll never get again, it's only going to predispose you for further wear and tear, possibly complications, or even a reduction of motion and strength as you move forward now. So, and most of the time, the fraying of the labrum is something that will happen as we age anyway. So when they go and you have an MRI and they state that there's fraying of the labrum, just note that that's something that is common with aging. It's not that we want that, it's just something that is common over time. But I would always argue against removing such a valuable piece of property from my body before trying conservative care.
Oh,
that's
100%.
kind of all I have to say.
Yeah. There is ways that you can train the joint to move fluid into the area to rebuild maybe a millimeter or two at most. I'm thinking probably one, because you have to take into consideration your body weight walking against gravity. Already that is going to put more pressure in this suction cup type joint. And if you're able to move around the edges, that can help rebuild the edges and also take pressure off the inside portion where most of the pressure is on. But over time, and we're going to get to this here in osteoarthritis, you want to maintain the space of that joint and the fluidity of that joint as much as you possibly can. And often that is due to, the main way you can do that is through movement.
That was beautiful. That's it. And as those of you are sitting and thinking, oh, I really don't want this to happen to me, other than an incredible blow to that area from more than likely sports, maybe a traumatic fall or something to that nature, but most of the time it's from a sharp cutting motion where you were bearing weight and then a blow happened. So unless you're getting tackled every day at your job, which I don't know what other job has that, there's not too much to really worry about this, but over time, degenerative fraying and then tearing of the labrum is absolutely preventable. And as long as you maintain proper motion of the hip joint, which is what Doc will talk about towards the end, there really isn't much to worry about this. So how you can predispose yourself to getting a labral tear is, of course, the first step will be osteoarthritis, is a more common condition you'll have first before something severe like that happens. Or at least narrowing of the labrum, maybe not a tear at the utmost end of it, but the severe narrowing over time from the narrowing of the joint due to OA is probably the most common thing will find with labral change, just due to poor biomechanics, all the things we're about to get into. So Doc, first, before we do, hip OA, how does it present with patients and really what's going on?
Yeah, so hip osteoarthritis, that's oftentimes where there's pain in and around the hip area. It can also mimic referral pain from like the lower back. You're going to notice a lot of stiffness, tightness, very limited range of motion. Also, you might notice limited gait. So like when your stride length might be much shorter strides instead of normally fluid motion of how people walk would be another good way to present itself. There's certain times to where, depending on if there are osteophytes or bone spurs on the hip, there could be sharp pain with certain movements that you find yourself in. A key way that we look at and assess that is either X-ray. If that doesn't give us enough information, we could then go MRI. But most commonly when we see osteoarthritis, it's going to be bone spurs on the outside portion of the hip or lateral portion, and the space is going to be diminished with tightness and stiffness around it.
And a lot of people need to realize too with hip OA, osteoarthritis is a symmetrical narrowing of joints. So if you have a duplicate of the joints, they more than likely will narrow symmetrically. So what that means is when we take a picture of the right hip joint and you're only having right hip joint pain and we're looking at it and we're saying, oof, this isn't looking too hot, more than likely it's happening on the other side. And why the brain chooses to only have pain in one area at sometimes is still very difficult. We are still trying to understand the pain mechanisms of the brain, but that's just something that you need to note too, is when we're taking care of one thing and you have a duplicate, make sure to take care of the other as well. So when you're going through rehab and you're just focusing on the area that has pain, we still want you to absolutely take care of the opposite, because again, more than likely it is narrowed at the same time symmetrically. So with hip OA, you'll notice it's stiff in the morning, better with activity. You'll notice NSAIDs can usually help diminish pain. It's definitely an inflammatory component to it due to the arthritic component, but more than likely, as it continues to wear out and it gets to a point of bone on bone, that labrum has now deteriorated to a point where we aren't going to regain that again. And so why we as chiropractors talk so much about preventative care is because there's no coming back from a lot of these drastic changes to our body. We like to think that there are miracle drugs and cures and surgeries out there that just get us back to how we were prior, but very rarely do we actually get that extent. And even with a full hip replacement, we still now, it's not like you have a brand new joint. There's limitations to that replacement. There's limitations to the amount of weight you can put on that prosthesis. There's limitations in actually how much range of motion you have with that prosthesis. And so to think that it's just, okay, well, once it gets to a certain point, surgery will fix me, I don't need to worry. It's not like you have your life back. It is a adapted way of living with this prosthetic hip joint. So basically, as the hips continues to narrow and narrow and narrow, the labrum starts to run out of space. It's now bone on bone. It's very painful. You have limited range of motion, stiffness, just like Doc said. There might even be swelling in that area. What's left? Well, if you had been maintaining that joint prior, we could have prevented this from happening. But if we've gotten to this state, unfortunately, hip replacement is something that is usually a last-ditch effort at someone who's got complete bone-on-bone infusion. So what I found is that you can still absolutely try to manage this without surgery, and I'm not saying you have to jump right into it, but there will come a point where if the quality of life you want is with way better range of motion and less pain, once that hip becomes completely bone-on-bone, it can be quite painful and excruciating. Doc, anything with that?
Absolutely. And every time you walk, run, it puts 2.5 times your body weight on just that one plant foot with every stride. So when Doc said the prosthesis, or like that metal-like structure that got put in replacing your hip joint, and how it can only withstand so much load, if you want to go for a run for miles at a time for years on end, there's going to be limitations. That metal will wear down and you're going to need another replacement. So again, paying attention to what's involved, and even if you have that surgery too, the tissues around there and the communication to the brain, you have to reconnect that via proprioception work, via strengthening, stabilization, mobility. It takes months, if not years, to rehab such a big joint that is used to hold our body up and to move on an everyday basis. There's a study with Franzen, I think back in 2018, to where they noticed improvement of moderate to mild osteoarthritis that has improved through exercise, which is awesome. It's pretty much, if you move the joint specifically at that joint, it can ease up the muscle tension, it can ease up the pain itself, and improve quality of how you function. But once you get to a point to where it's close to bone and bone, like Doc said, there's not many other ways around it. It's monitoring and maintenance for your structure for the rest of your life.
And don't take for granted the movement you have now.
Yes.
Use it. And just, well, you don't realize how difficult some of this rehab can be when you're at that state.
It was painful.
Once you get there, you wish you would have taken care of yourself way prior to getting there. And I know it's tough to put yourself in that state right now, but just trust us. From what we've seen over the years, so many patients who come in just with exacerbated pain from advanced OA, they definitely wish they would have taken care of themselves way prior to that ever getting to that state. So,
and I know Doc brought up one aspect where it's usually symmetrical. It happens on both sides. This, if you have one hip replacement, you might have to repair the other one. However, if you do have compensatory factors up the chain or compensations, like especially scoliosis, if there's a curvature in your lower back or a mix thereof, it can put way more pressure on one hip joint versus the other, to where, especially at a younger age, looking at the hip space is going to be incredibly important in comparing those two. I think a good follow-up, if you do know you have scoliosis, to have the medical practitioner take a look at the hip joint space, and are they equal? Is it starting to affect your life? Because once this space diminishes, there's limitations, much like we said, but there's other factors that can make it only on one side versus bilaterally. But just one thing to pay attention to.
Good point.
Or short leg, long leg, via either do a surgery or accident, or just you're naturally born with a short leg. Either it's going to be not as long of a femur, tibial fibular bone. There's other factors again with that too, but
yeah, good point. Good point. And kind of moving on to the next one, a lot of hip OA can be constant pain, but what can mimic another close in proximity to constant pain is bursitis instead of osteoarthritis. And I think a lot of people get confused on what is actually causing their pain, and even physicians can struggle diagnosing it correctly. So Doc, what is bursitis? Where is it in proximity to where hip OA is happening? And what are some of the little intricacies of pain patterns, differences-wise?
That's a good point. When you look at bursitis, it's inflammation of the bursa, often due to chronic overuse of tightness overlying it, especially muscle tendinous structures. Now, bursas are meant to have glide of the overlying tissues. There's a lot of bursas in the knee, there's a lot of bursas in the hip, shoulders, but a common one that docs are referring to, especially related to osteoarthritis of the hip, is a bursa on the outside portion of your hip bone. This could also have pain or just tender tension on just the outside of the hip. That could lead to us understanding, okay, is it just a bursitis or is it something going on with the hip capsule? Now, when you look at this, it can also have, at times, referred pain going down the leg, but that often is due to the muscles overlying it being incredibly tense and tight. So there's a few structures involved, some of which is there's a tensor fascia lata, or the TFL, that goes more on the front portion of the hip and attaches down to your IT band. There's also the quad complex, to where the quadratus lateralis, which is a muscle on the front outside portion of the front of your thigh, that also has and goes up to the hip. And then there's also tissues on the backside of the glutes that attach over to the outside of the hip as well. So there's a lot of structures that come to this point, to the neck of the femur, to the outside portion of the bone, to where if that bursa was inflamed over a period of time, it can lead to other problems and symptoms affecting other areas around. We can often see this where people, if they have a dip in their hip, or when they walk, they have weakness in the gluteal region, if we will, and there's more specifics with that, but that will lead to more pressure on the outside. If you have constant pressure, or for example, if you're a hockey player, you constantly get hit on the side, that can inflame the bursa. I know we're gonna get to other referral patterns. Is it just the hip? Is it the bursa? Is it coming from the lower back? Kind of how is everything involved there? But Doc, is there anything else you got?
Yeah, and it's tough because a lot of the patients that we see with a bursitis have some signs of OA too. So making sure that you understand the differences. But primarily bursa without OA, you're not going to see a change in range of motion. With OA, you'll see that, but with a bursitis, it doesn't affect your joint range of motion. It's just the pain pattern that you have on the lateral hip. Doc hit on how it can refer down. Usually with hip OA, we don't see a lot of pain referral down to other parts of the leg. Not to say you can't have knee pain with hip OA because of how it changes, but the pattern itself is definitely more lateral and it's constant. With OA, as you rest at night, it can usually go away. With bursitis, for some reason, it just, if it's still inflamed, tough to get that bursa to calm down sometimes. And it's a more constant pain versus intermittent pain. And then the last thing I wanted to say with bursitis is, for those of you who lie on that side and then have that pain when you wake up, again, you're, irking or making that bursa even more compressed and painful. And it could be then exacerbated with added pressure to that side, like you said, especially if they're, hockey players shearing that or just hits to that area. It's the same as if you're just lying on it in bed. It can absolutely still irk or inflame that bursa.
When you look at ways that you can go about treating it, there's NSAIDs can help for the inflammatory response. Usually PT lifestyle modifications, if your hips go back and forth, especially with a weak glute medius, which helps stabilize the stabilizing hip as you plant and walk forward. Like if you notice when people walk, if there's like dipping of the hips, that can also lead to pressure on the outside. So you'd want to go strengthening, usually doing stabilization of single leg stands, positions, the hold, the strength in the glutes. So there's some corrective exercises. Ice can work to a certain extent really well. A corticosteroid injection can help to a certain regard, but it might not correct the problem long term. With steroid injections, it's a hit or miss. It may work, it may not. I would estimate about 50-50 shot on that one.
Probably.
But it's not going to get rid of the problem.
And the effects you do see are short term.
Yeah.
So really the goal primarily to have long-term outcomes is to remove the interference of what's causing the bursa change. I would say that's going to be your thought process behind making sure that this doesn't come back. So If you're sleeping on your side, if you're doing a lot of lateral movements, if you cross your legs and it's like, there is a reason to why your bursa continues to be mad at you. So making sure you're just conceptualizing that and thinking about, okay, what things am I doing that's making it worse? And do I remember at which times of the day it is worse? And what did I do just prior to when it was worse? And just try to kind of reverse engineer that process.
Even foods that you consume
For
as well.
sure.
That's another part that we didn't bring up.
The inflammatory component, right?
Yeah.
I don't see a lot of chronic bursitis. That's really the only time I see chronic bursitis is when we have a really weak glute complex like you talked about. So why would that be? Again, it's causing a Trendelenburg sign where the hips, if stable and have no weakness, should not dip down when you walk. And I know some of the easiest way to think about this is when you watch usually a heavier set person have a dip with their hips as they're walking. And with that amount of weight, more than likely they're sedentary and they're not training. It just causes such a weak posterior hip complex. And when you see what I would call like a dipping stride, where it's almost like a figure 8 motion as if you were to track it, it causes so much external strain on that lateral hip, which for sure can cause a worsening of that bursitis. So we're going to get into how to make sure that you can correct that if you do have it in just a short while here. So a lot of patients will explain to us hip pain as kind of this grasping fashion. So it's, I have hip pain, and the hip is incredibly close to the pelvis, which the pelvis is then incredibly close to your sacrum and then to your low back. And so this entire complex is very important to make sure that you can delineate between all of it, because the amount of pain that can come from one area and then to refer to others in such close proximity can create a nightmare for physicians if you don't understand these pain patterns. So just before I get into that, I'm going to talk a little bit about the complex. You have your lumbar spine here, which is connected to the sacrum. Now, the sacrum creates a connection to your pelvis via the sacroiliac joint. It's called the SI joint. And it's not a very movable joint, but it is housed by a lot of very strong muscles and tissue. We have the lumbar spine here, and it connects to the sacrum. The sacrum connects to the ilium, which creates this sacroiliac joint, SI joint. And this joint is not a very movable joint. What it does, though, is houses the incredibly large gluteal tissues, connects close to the backstrap muscles, and we can create, a lot of the times we're very flexor dominant, and so it's tough to really train the posterior chain here. And what we'll find is these areas can become weak quite quickly if you're not walking properly and if you have sedentary lifestyle and what have you. So lumbar spine, sacrum, ilium, and then the ilium, the bottom portion, is what connects to the femoral head and what creates your hip joint. So when it comes to certain pain patterns, there are times where we have compressive symptoms in the low back, which radiate down the side of the hip or the back of the hip, or even down the leg. There are times where we have facet joint pain. It's the smaller joints in the posterior portion of the low back. And when we have facet pain, it can actually come down the back of the glute, even down the back of the hip, which can again mimic hip pain, but primarily it's being generated from the lumbar spine. We can have what's called Main syndrome, which is cluneal nerve, which are superficial nerves that come out of the low back, and they have compression from tight tissues or compensatory patterns. And these cluneal nerves can go straight into just the glute areas. And so you'll get low back pain, but it's kind of coming off into the butt area as well. And a lot of people, when they think of the hip, they almost also think the butt is a part of the hip. But when we're talking just straight physician to physician anatomy wise, the hip, when someone says they have hip pain, and so when we talk to each other, it's really just mostly the groin or lateral hip. That's where we talk about someone having anatomical hip pain. But in close proximity to that is the glute butt area and the SI joint, where someone can have SI joint glute pain. And then next to that is the sacral or low back area, where someone can have low back pain. So we want to make sure we can separate all three of these areas, because a lot of them can overlap as far as pain patterns go. And we want to make sure when we're asking our patients what pain they're having, we can get that history and that story as accurately as possible, because it'll affect where we think the pain is coming from. And I bet you any provider who treats musculoskeletal issues can absolutely agree and attest to is we started at the low back and we ended up at the hip, or we started at the hip and we ended up at the low back as far as where the pain was coming from, because it is such a complex between all three of them, and the pain patterns can be very close together. So starting off with the low back, you're going to have diffuse low back pain where it's just kind of around the lower portion of the back, and maybe you'll get into closer to the tailbone. So when it comes to low back pain, it's going to be primarily right here, unless, of course, the nerves are included as far as compressive issues, like I said with Main syndrome and Facet syndrome. SI joint pain is going to be more on the glute. That's where you're going to have maybe off to the side, right on where the sacrum meets the ilium. It's going to be more glute. It might come down to the hip a little bit, but just a primary SI joint area. It's going to be slightly off to the side of the low back and down by the hip. And then when we have anatomical hip pain, it's going to be mostly groin. Maybe it's off to the side lateral hip. And again, if it's including the nerve, we're going to have referrals of pain. But if we're just talking strict anatomy, where that's where the pain is being affected, that's where the just diffuse pattern will be without any referral pattern. Now, like I just talked about, we start talking nerves, that's going to go from low back to hip. Hip might have femoral nerve, where we start seeing down into the thigh, SI joint, and Main syndrome can have any chance of cluneal nerve entrapment, which we'll start to see down the back of the body. So the main thing that I want you to take away is it's very important for us as physicians to know where you are feeling the pain starting from and where is it going to. That will help us out a lot. And of course, for yourselves, so you know what's going on. And two, if it's just in one area, where is the closest proximity to where that area is, so you know exactly how to understand what's going on with the issues that you have and how to obviously communicate that to your providers.
Yeah, as you can see, there's a lot of complexities of how the nervous system regulates the pain and how everything's kind of combined together. I think Doc did an awesome job showing the difference between many different areas, the lower back, the facets, the SI joints, the outside portion of the hip. If this seems complicated to you, other than movement, I would definitely highly suggest go see a trained medical professional that deals with a lot of musculoskeletal conditions, but also has a really good idea of how the nervous system works.
So I hope I didn't confuse you with all of that, but like Doc said, it's incredibly complex treating the body, and you need to understand these patterns, and you need a provider who doesn't just look at one area. And the second we see someone with low back pain, we already automatically at this clinic look at the other areas above and below it. Same as the SI joint, same as the hip. We all know how interconnected all of these are. So when we are looking to manage this on your own, there are tools that you can use to, at least as far as the anatomical hips concerned, since that's what we're on today, things that you can do to make sure that you keep internal range of motion important. There's things that you want to make sure you don't wear out your labrum. All the things that so we avoid surgery, that you can do. And Doc's going to do a great job of breaking that down for us today.
Cool. So let's go into a few things, much the same with every other part of the body, with every other series or video. We want to go through the workspaces, or how much we can move our femur in that hip joint to the biggest circle possible. So I'm going to get to a couple things here in a second. This is going to be an assessment tool. This is also going to be an exercise tool for the maintenance of your hip joint moving forward. But when we go into this, there's a few factors that we have to pay attention to. First off, we want to make sure the movement is going specifically the best we possibly can, only through the hip or ball and socket joint. So that's going to involve stabilizing, either keeping our legs straight, and whether it's the thigh and the calf, or you can keep the knees bent. Easier knees bent versus straight, because less pulling tension coming down. But if you're more advanced, if you feel like you want a challenge, I suggest going legs straight. You also want to make sure that you're stabilizing your core and you're not tilting your pelvis. So you can do this a couple different ways. When you go through hip workspace, let's start off standing first, and ideally going up against a wall, holding an object. If you have to hold a stick in front of you, awesome too. And much like I said, easier with knee bent versus straight leg. But when you go through this, there's a few things that we want to start. By moving the ball and socket through the edges of the joints, we want to first start off with rotation. So that's going to involve ideally crossing your leg over of the leg that you want to move. We're going to then bring the knee up as the foot's on the inside. Again, we want to make sure we're stabilizing and contracting all the muscles of our planted foot and our core and our pelvis. We want to go from inside to keep everything externally rotated to where you can't anymore. From there, what we want to do is try to turn our foot backwards, bring our glute back and around, and then from there start to rotate so our foot is facing back straight forward, and then bring our knee in. You can tap the ground, bend, bring your leg backwards, rotate out, off to the side, and then come back and try to bring your foot forward and across your body. So I'll do a little bit more quicker so it'll make a little bit more sense. Start here, turn back, come back around, tap, in an opposite direction as well, okay? Now when you do this, if you open up and you notice your pelvis coming off to the side, hold on to the side of the plant foot so it restricts your movement. So you might go from here to here. And that's where we're focusing on training the joint. Now we can also do this a couple other ways. You can also do this laying down. This could be on the bed, on a couch, to a certain extent on the couch, ideally on the bed. We want to first start by bringing our leg over, and then from there, knee up to your chest. We're going to bring our leg up off to the side. Try to bring our foot backwards as much as we possibly can, and then come back down. Lift the leg back up, rotate our foot forward, and then back around. Now it's easier, if it's harder for you to stand and stabilize, I'd go to the floor. And again, level 1 to 3. 1, nice, easy, light motion. There shouldn't be pain or restriction. If you do notice sharp pain, especially on the outside, come up. If there's pain, diminish the angle, try to go around. If there's still pain, still try to go around and go backwards. And then that's the circle or oval now that we want to move in, okay? Over time, you want to build that up, and that area should shrink. But if there's other problems going on, if that doesn't subside after like a month or at least a few weeks, then I'd probably go see a physician so we can look at more in depth what's going on. Either get the inflammation under control, oftentimes bursitis or impingement of the hip, or there's just osteoarthritis as well, where the hip capsule is limited. Now, level 3 is where you want to add an ankle weight through the same range of motion movement and go from there. Now, this is training the hip joint specifically. If you want to train the muscles overlying the hip, then you can go into reps. So you can bring your leg back and forth. If you notice popping, like let's say I come off to the side, oh, popping on the front. We want to spend as much time there as possible. So we'd go hold, positional holds with a little bit of movement of rotation and then go back through. There should be less popping, but it's going to take days to build that up. With the first line of communication to the hip is rotational work. So like let's say there's osteoarthritis, it's severe, there's not as much joint space. Maybe then we want to stand on the stairs or a platform so the leg's hanging down. From there we can do small circles of your foot facing forward. You can turn your foot in, again small circles, foot outwards, small circles. So we have that decompression and having the muscles and tissues around there re-regulating to the nervous system that, okay, it's safe, we can turn off some guarding, it'll ease up the pain. Again, we're going to need days, weeks, if not months to a certain extent, consistently of just that movement itself. So the best way that we can maintain the structure is by moving the joint because it's the first signal to the brain. It'll also help overlying muscles, lead to less compensation to your lower back. And even if you, or when you go into this movement, pay attention. Are you hiking your hip up? If so, you could be compensating to the lower back. So you want to make sure that that hip is down as well. It might limit how big you can move. But again, we want to focus on just the hip joint. We don't want to focus on just the biggest movement because your body will compensate in many ways to re-regulate itself.
Good point.
Now, a couple other areas though, with the pelvic floor, there's pretty much three main ways that you can train the pelvic floor. One of which is via Kegels. So it's like squeezing your tailbone in and relaxing out. There's a lot of tissues on the pelvic floor or in that bowl that'll squeeze and relax. And the Kegels is one of the best ways. So if you're pregnant or were pregnant and want to start training and you have some lower back discomfort, that's where I'd start. Just squeezing your glutes back and forth. Now the other area is two other small muscles, one smaller than the other. One is obturator internus, which goes on the front portion of the pelvic floor and goes to the outside portion of your hip. It's called obturator internus. Now, because of where it's at, you want to ideally lengthen. So you can do this via bringing your legs in and apart laterally. Ideally, the best way that you can go about that, if there's no pain, is laying down either on the bed. This one could be better on the couch. And you want to force your feet together, putting pressure together, and then lifting your legs up. You can rock your knees side to side. That's going to put a muscle contraction in that muscle belly on the front and bleed all the energy into that front part of the pelvic floor. Now the other one is what's known as the piriformis, which goes and starts on the front side of your tailbone and goes to the outside portion of your hip. Now same thing, either we want to lengthen it or if we want to go into muscle contractions, just bring your leg up, positional holds, or back down, or for reps. The other way, if you bring opposite direction, feet together, and then lifting your legs up off the ground, and then you can rotate side to side. Again, positional holds, or we can go for reps, just lifting your legs up, just as long as the feet are pushed together, okay? Those are the three ways that you can train the pelvic floor from the front side, back side, and the deep bowl structure. You can combine other movements as well. Now there's a few others that I have yet to bring up, or it's the first time bringing up to the public and even patients. When you go into Kegels, ideally laying on your back on the bed, couch, coming up into a bridge. When you're in a bridge, I want you trying to squeeze your glutes, which gets one, the piriformis, two, the pelvic floor, and then you can either bring your legs together and then squeeze, and then try to bring your legs apart as far as you can in a bridge, and then try to squeeze your glutes. The other is in a little bit more advanced stage, is coming up single leg bridge. Doesn't matter where this other foot is too much. Squeezing your glutes and then bring your legs out and in as you're holding your glutes contracted. Again, that's going to force more movement of the tissues that go from your tailbone or sacrum out to your hip, which can also help re-regulate pelvic unleveling, help fix a stuck SI joint. It's pretty much forcing the muscles to move your bones to get rid of the restriction, thus less pain. So I'd give those a go. You want to build up time under tension first, positional holds. Let's say holding that as long as you can. And again, you shouldn't be moving into pain. The next from there, you can go into reps for either down and up or legs in and out. You can add rotations. You can explore a little bit with this. But those are some of the ways that you can maintain the pelvic floor and also the hip complex long term.
You wore out? My goodness. I'm just sitting here watching you. So that was a beautiful breakdown. And to be honest, we might even have to have Doc do that on a separate video if you guys want. And just because we might need some better angle shots of that too. But if you have any questions with that, please let us know. We can always create a better shot. But try that out. Again, these were just ways to continue to supply good, healthy, bleeding energy into these areas so that they can have great range of motion, but not only good function, especially when it comes to pelvic floor. I don't think a lot of people realize, Doc, do men need to work on their pelvic floor?
Oh, absolutely.
And a lot of people don't realize that.
No.
And to this day, I think most people just associate Kegels with the proper function of a women pelvic floor, which not to say that it isn't, but men especially too, as we continue to sit for long periods of time, our pelvic floors will become affected. Absolutely.
Especially for prostate health.
Yes, seriously. So if you were a male watching that thinking that wasn't for you,
try it.
Boy, are you wrong, because it's incredibly helpful, especially if you are having groin pain, tightness in the hips, those certain pain symptoms or patterns. Boy, and you have yet to find something to help with that. I'm telling you, you'd be amazed at what proper pelvic floor function can affect not only in women, but in men as well.
Yes.
Yeah.
Absolutely. Yeah.
So I think that was it, Doc. We'll hopefully get all that out to you in a better form if you would like it, but please give it a try. And thank you guys so much for watching. This was the HIP Podcast. Like, subscribe, share, and again, just thank you guys so much for continuing to support us. Thank you guys so much. We'll see you on the next one.
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the Functional Code. Until next time, stay well, stay informed, and embrace the science of living well.